Hello friends, I'm Dr. Jeevitram. Today I will discuss about acute pancreatitis and its treatment. Introduction. Acute pancreatitis is a condition in which activated pancreatic enzymes leak into the substance of the pancreas and initiate the autodigestion of the gland. Etiology of acute pancreatitis. Common causes 90% gallstones, alcohol, idiopathic. Rare causes metabolic, hypercalcemia, hypertriglyceridemia, drugs, thiazide, azathioprine, sodium valproate, pentamidine. Infection, mumps, Coxsackie virus, post-ERCP due to back pressure of contrast into ductal system, trauma, organ transplantation, post-surgical. Other causes of acute pancreatitis: abdominal trauma, medications, infections, tumors, genetic anatomical variants, high triglyceride levels, high calcium levels. Pathophysiology of acute pancreatitis. The pancreas secretes the digestive enzymes as proenzymes, which are activated in the intestinal lumen. Acute pancreatitis may result when activation occurs in pancreatic duct system or acinar cells. May include edema or obstruction of the ampulla of Vater, resulting in reflux of bile into pancreatic ducts or direct injury to the acinar cells. The pancreas shows edema and necrosis. The release of enzymes lead to fat necrosis both in the pancreas and in the peritoneal cavity. Premature activation of trypsinogen into trypsin while it is still in pancreas, resulting in autodigestion of the pancreas. Clinical presentation of acute pancreatitis: mid-epigastric pain with tenderness, sudden severe pain occurring after within 12 to 24 hours of a large meal or alcohol. The pain is persistent and radiates frequently through the back to either shoulder or to one iliac fossa before spreading to involve the whole abdomen. Exacerbated on walking and lying supine, relieved on sitting and leaning forward. Nausea and vomiting has always been the presentation of acute pancreatitis in the majority of cases. When pancreatitis is extremely severe, it mimics septic shock, fever, hypotension, respiratory distress from ARDS, elevation of the WBC, and a rigid abdomen. Abdominal examination: tenderness in epigastrium. Although severe pain, there may be little or no guarding of abdominal muscles at first. Later, the upper abdomen becomes tender and rigid as peritoneal irritation increases. Mild abdominal distension if paralytic ileus develops. Severe advanced cases may develop bruising and discoloration in the left flank. Gray Turner sign due to tissue catabolism of hemoglobin and around the umbilicus. Colen's sign due to hemiperitoneum. These are the rare and late signs of extensive pancreatic destruction. Complications of acute pancreatitis. Complications: shock and renal failure. Causes and features: pancreatic failure is associated with leakage of fluid in the pancreatic bed, also alias with fluid-filled loops of bowel, leading to pre-renal azotemia and then acute tubular necrosis. Hypoxia, ARDS due to microthrombi in pulmonary vessels. Hyperglycemia due to disruption of pancreatic islets. Hypocalcemia, sequestration of calcium in fat necrosis. Hypoalbuminemia, increased capillary permeability. Necrosis, abscess, rising fever, leukocytosis, localized tenderness and epigastric mass. It may be associated with left-sided pleural effusion and enlarged spleen due to splenic vein thrombosis. Pseudocyst, Encapsulated fluid collection with high enzyme content, usually less than 6 cm sized pseudocysts, resolve spontaneously. They may become secondarily infected, requiring drainage of abscess, ascites, gradual increase in abdominal girth, and persistent elevation of serum amylase. In the absence of flank abdominal pain, it results from rupture of a pancreatic duct or drainage of pseudocyst into the pancreatic cavity. Gastrointestinal complications: upper GIT bleeding, gastric or duodenal erosion, duodenal obstruction, compression by pancreatic mass, obstructive jaundice, compression of common bile duct. Investigations: serum amylase, increased level of threefold or more the normal value indicates acute pancreatitis. However, other causes of elevation should be excluded, such as mumps and perforation or the infarction of the intestine. Levels turn normal after 48 to 72 hours, even with continuing of pancreatitis. Serum lipase should also be sent that remains high for 7 to 14 days. Persistent elevation suggests pseudocyst, pancreatic abscess, or non-pancreatic causes, intestinal obstruction, mumps, narcotics. Serum lipase remains elevated for 7 to 14 days. It is diagnostic. Other laboratory findings: WBC, glucose high, but may be elevated, serum calcium low in 25% of cases, AST, bilirubin, alkaline phosphatase are transiently elevated, serum albumin is low in 10% of patients and indicates severe pancreatitis. Markedly elevated LDH suggests poor prognosis. Serial assessment of C-reactive is a good indicator of progress. ABGs show hypoxia. Plain X-ray abdomen, it may show gallstones, sentinel loop, colon cut off sign, features of paralytic ileus, left pleural effusion, or collapsing of lung. CT scan useful in detecting large pancreas, pseudocyst, abscess, hemorrhagic pancreas. Presence of gas bubbles indicate abscess. Ultrasound to detect gallstone and biliary obstruction, and serial assessment of pseudocyst. Although in the earlier stages the gland may not be grossly swollen and may be missed on ultrasound. Differential diagnosis: perforated peptic ulcer, acute cholecystitis, and biliary colic, acute intestinal obstruction, renal colic, myocardial infarction, vasculitis, pneumonia, diabetic ketoacidosis. Management of acute pancreatitis: in most patients, it is a mild disease that subsides spontaneously within several days. Withhold food and liquids by mouth, bed rest, and in patients with severe pain and ileus nasogastric suction. Supportive treatment: bed rest, NPO, IV fluids, saline or whole blood, nasogastric suctioning. If severe nausea, vomiting, or development of paralytic ileus, pethidine 3 to 4 hourly to control pain. Avoid morphine. Oxygen for hypoxia. Ventilator may be required for ARDS. Dopamine may be required for shock non-responsive to fluids. Calcium gluconate IV only if hypocalcemia is associated with tetany. Fresh frozen plasma for coagulopathy. Serum albumin for hypoalbuminemia. Insulin for hyperglycemia. Total parenteral nutrition for severe cases. Antibiotics: prophylactic broad spectrum antibiotic is given even in sterile pancreatitis to prevent infection. Imipenem 500 mg IV 8 hourly, or cefuroxime 1.5 g IV 8 hourly. ERCP when severe pancreatitis results from a stone in biliary tract, particularly if there is jaundice or cholangitis. ERCP with endoscopic sphincterotomy and stone extraction is indicated. Surgery. Cholecystectomy should be undertaken within 2 weeks of resolution of pancreatitis. Patients with necrotizing pancreatitis or abscess require urgent endoscopic or minimally invasive retroperitoneal pancreatic necrosectomy to debride all cavities of necrotic material. Pancreatic pseudocyst can be treated by draining into stomach, duodenum, or jejunum, performed after 6 weeks once capsule matures by surgery or endoscopic cystogastrostomy.